Welcome to the RadOnc Smart Review CNS Cancer Series.
Great to be here. Today, we're diving deep into a really critical topic, managing brain metastases after surgery, specifically stereotactic radiosurgery, or SRS, to the surgical cavity.
Yeah, this is essential stuff. We want this to be like a practical workshop, giving you the clinical insights and the board review knowledge you really need.
Absolutely. We'll cover everything from workup to the latest trials and treatment techniques.
Okay, let's kick things off with a scenario you'll definitely encounter. Imagine a 65-year-old woman, history of breast cancer. She comes in and complaining of new headaches, maybe some trouble with balance, ataxia.
Right. Pretty classic presentation.
And her brain MRI magnetic resonance imaging shows a single metastasis, fairly large, maybe 3.5 centimeters, sitting in her right cerebellum.
So given the size and the fact that she's symptomatic, the neurosurgeons perform a gross total resection. They believe they got it all out.
And the post-op MRI looks good, confirms a clean resection cavity. Now she's in your clinic, it's about 3 weeks after surgery, ready to talk about adjuvant radiation. What next?
This is such a common and important decision point. It really tests your understanding of the current standards.
You know, if this were maybe 20 years ago, the answer would have been simple. Whole brain radiation therapy, WBRT, that was just what you did.
Exactly. But things have changed dramatically. Now we have post-operative SRS, which is, well, much more targeted and generally less toxic for the patient.
Okay, let's unpack that. The first, maybe obvious question is, if the surgeon did a gross total resection, why do we even need to radiate the cavity at all? Seems like the job's done, right?
It does seem that way initially, but, and this is really the core issue, even with the most meticulous surgery, microscopic tumor cells are inevitably left behind at the edges of that cavity.
So just watching and waiting, observation, it's just not enough.
Definitely not. The risk of the tumor coming back right there in the cavity is unacceptably high if you do nothing else.
And we have solid evidence for that, don't we?
We absolutely do. The landmark Patchel 2 trial randomized patients with a single resected brain meant to either WBRT or just observation.
And the results?
They were striking. The observation arm had a 1-year local failure rate, meaning recurrence in the surgical bed of 46%, almost half.
Wow. Nearly 50 chance of it coming back within a year.
Exactly. And more recently, there was the MD Anderson post-op SRS trial. Their control arm, which was essentially surgery alone, confirmed this. They saw a 1-year cavity recurrence rate of 57%.
57%. So the takeaway is crystal clear.
Absolutely.
Yeah.
Observation after resection is simply not the standard of care. You must do some form of adjuvant local therapy to prevent that recurrence.
Okay, so we've established treatment is necessary. Now the big question, what kind of treatment? SRS or the older standard, WBRT?
And luckily, we have level 1 evidence to guide us here. 2 major phase 3 trials directly compared post-operative SRS to post-operative WBRT.
Let's talk about those. Which one came first?
Well, around the same time. But let's start with the MD Anderson trial by Mahajan and colleagues. Published in 2017, it's a single institution study.
What did they look at?
They took patients with 1 to 3 resected metastases and randomized them to either SRS to the cavity or, actually, this one compared SRS to observation, reinforcing the need for treatment.
Okay. So what was the key finding there?
It showed that adjuvant SRS dramatically improved local control compared to just watching. The 1-year cavity control rate went from 43% with observation up to 72% with SRS.
So SRS clearly better than doing nothing.
Undeniably. But the truly practice-changing trial, the definitive one, is the North Central Cancer Treatment Group study, NCCTGN 1070C, led by Dr. Paul Brown, also published in 2017 in The Lancet Oncology.
Okay, and 1070C, this one compared SRS directly to WBRT after surgery, right?
Exactly. Multi-center phase 3 trial. Patients with a single resected brain metastasis randomized to either post-op SRS to the cavity or post-op WBRT.
And what did this one show? I remember this being about trade-offs.
Precisely. It highlighted a classic dilemma. The primary endpoint was cognitive function. And on that front, SRS was the clear winner.
How so?
Patients who got SRS had significantly less cognitive deterioration at 6 months. Their memory, their thinking speed, it was better preserved. And they reported better quality of life, too.
That's incredibly important for patients. But what about controlling the tumor?
That's the trade-off. For tumor control specifically in the surgical bed, WBRT was actually superior.
Really? By how much?
The 1-year control rate of the surgical bed was 81% with WBRT, compared to 61% for SRS. So a 20% difference.
61 versus 81%. That sounds significant.
It is. But here's the crucial part, the absolute kicker. Overall survival, OS. How long patients lived.
Was there a difference?
No difference. None at all. The median overall survival was around 12 months in both arms. Patients didn't live any longer with a better local control from WBRT.
So let's synthesize that. What's the clinical bottom line from N1070C?
The conclusion is pretty clear. We can safely omit WBRT in the postoperative setting for most patients with limited mets. We accept that slightly higher risk of recurrence in the surgical bed.
That's 61 versus 81%.
Exactly. We accept that trade-off in exchange for significantly better cognitive outcomes and quality of life, knowing that it doesn't compromise how long patients actually live.
So postoperative SRS becomes the standard of care.
Yeah, that's right. It balances efficacy with toxicity much better for most patients.
Okay, great. So we've decided on SRS. Now let's get practical. How do we actually contour for post-op SRS? What are we aiming at?
Good question. The starting point is the gross tumor volume, the GTV. And for post-op SRS, the GTZ is essentially the entire surgical resection cavity.
How do you define that cavity?
You define it based on the T1 post-contrast MRI. You outline the whole hole left by the surgery, including any enhancing rim.
Okay, so GTV equals cavity. What about margins? Do we add a CTV or PTV?
This has been a bit controversial, or at least debated. Historically, some centers didn't add a margin. But now, the evidence points towards adding one.
What evidence is that?
There was a key retrospective study from Stanford, quite influential. They looked at their outcomes with and without adding a margin.
And what did they find?
They found that adding just a 2-millimeter margin to the cavity, creating a planning target volume, or PTV, significantly improved their one-year local control.
How much improvement?
It jumped from 79% without the margin to 94% with the 2-millimeter margin.
Wow, 79 to 94% just by adding 2 millimeters. That's huge.
It really is. So the takeaway now, and what's become standard practice, is to add a small margin, typically 1 to 2 millimeters, around the resection cavity GTV to create the PTV.
Got it. GTV is the cavity at a 1 to 2 millimeter margin for the PTV. Now, what about the dose? How much radiation do we give?
The dose is generally based on the size of the PTV, the target volume we just defined. The N1070C protocol actually provides a useful, standardized schedule.
Can you give some examples?
Sure. For a smaller PTV, say less than 4.2 cc's, the dose is typically 20 gray in a single fraction.
Okay, 20 gray, single shot for small ones. What about larger cavities?
As the PTV gets bigger, the dose has to come down to respect normal tissue tolerance. So, for instance, for a cavity between, say, 20 and 30 cc's, the dose might be reduced to 14 gray. Again, usually in a single fraction.
14 gray. And what if it's even bigger than that? Can you still do single fraction SRS?
Generally, for very large cavities, single fraction SRS carries too high a risk of radiation necrosis. That's radiation damage to the surrounding healthy brain tissue.
Right. Necrosis is a major concern. So what do you do then?
For those larger cavities, we often switch to a fractionated approach. We break the dose up into smaller daily doses over several days.
Like what kind of fractionation schedules?
Common ones are maybe 27 grays delivered in 3 fractions, or perhaps 30 gray in 5 fractions. This allows the normal brain tissue some time to repair between doses and significantly reduces the risk of necrosis while still effectively treating the target.
Makes sense. Manage toxicity by fractionating for larger volumes. Okay, let's shift gears slightly. There's a specific pattern of failure after surgery we need to discuss. Nodular meningeal disease, or NMD. What is that exactly?
Yeah, NMD it's a unique and concerning complication. It happens when tumor cells are thought to spill into the cerebrospinal fluid space, the subarachnoid space, during the surgery itself.
Spillage during surgery?
That's the theory. These cells then seed along the meninges, the lining of the brain, and can grow into these little nodules. It's a different pattern than just recurrence in the cavity.
How common is this NMD after surgery in SRS?
There was a really important study on this from Dana-Farber. They looked at patients who had resection followed by postoperative SRS.
And the risk?
They found the risk of developing NMD was actually quite high, up to 25% in their series.
25%. 1 in 4 patients.
Yeah. But what was really telling was the comparison group. Patients who were treated with SRS to an intact metastasis, meaning no surgery beforehand.
What was the NMD risk for them?
0%. None of them developed NMD.
Wow. So that strongly implicates the surgery itself as the main driver, the main risk factor for NMD.
Exactly. It really points to surgical technique, location, and maybe tumor biology playing a role in that spillage.
So are there specific things that increase the risk of NMD happening after surgery?
Yes, definitely. We've identified a few key risk factors,
Hmm.
and I actually like to use a simple mnemonic to remember them. BPP.
Okay, BPP, I'm ready. What does it stand for?
All right, so B is for breast cancer histology. For some reason, breast cancer mets seem more prone to this type of spread after resection.
Okay, B for breast. What are the P's?
The first P is for posterior fossa tumors. That location, the back of the head near the cerebellum and brainstem, seems to be higher risk, maybe is harder to contain things there surgically.
Right, posterior fossa.
And the final P.
The final P is for piecemeal resections. This means the surgeon couldn't remove the tumor in one single piece. They had to take it out in multiple fragments.
Ah, I can see how that might increase the chance of cells escaping.
Exactly. Think about it like trying to move a box full of really fine glitter. Even if you're super careful taking it out piece by piece, some of that glitter is probably going to escape and float around, right?
Yeah, good analogy.
It's kind of like that with tumor cells during a piecemeal resection, especially in a tricky spot like the posterior fossa, and maybe with a slippery histology like breast cancer. BPP breast, posterior fossa, piecemeal.
BPP.
Got it. All right, mnemonic. Okay, let's consolidate. Time for our clinical pearls section. What are the absolute must-know points from today?
All right, pearl number 1. Observation after resection of a brain metastasis. Not standard practice. It results in a 1-year local failure rate somewhere between 45 and 55%. You have to treat.
Pearl number 2. The NCCTG N1070C trial is the definitive study comparing post-op SRS to post-op WBRT key finding. SRS gives better cognitive preservation and quality of life with no difference in overall survival. That makes SRS the standard of care.
Pearl number 3. Remember the trade-off. WBRT did provide better 1-year surgical bed control in N1070C, 81% versus 61% for SRS. We accept the slightly lower control rate with SRS for the significant cognitive benefits.
Pearl number 4, contouring. When doing post-op SRS, the GTV is the surgical cavity, and it's now standard practice to add a 1 to 2 millimeter margin to create the PTVY, to improve local control, based on data like the Stanford study.
And finally, pearl number 5, nodular meningeal disease and MD. Remember the mnemonic BPP. Key risk factors after surgery include breast cancer histology, posterior fossa location, and piecemeal resections.
Excellent pearls. Okay, feeling confident. Let's put this knowledge to the test with our board blitz segment. Ready for some questions?
Let's do it. Bring them on.
Question 1. A patient undergoes gross total resection of a 3-centimeter solitary brain metastasis. To minimize local recurrence risk while preserving cognitive function, what's the most appropriate adjuvant strategy based on level 1 evidence? Is it A, observation with serial MRI-B, WBRT to 30 gray in 10 fractions? C, stereotactic radiosurgery to the surgical cavity? Or D, systemic chemotherapy?
Okay, thinking through this. We want local control and cognitive preservation. Observation fails on local control. WBRT hurts cognition compared to SRS. Chemo isn't the primary local treatment here, so the answer has to be C, stereotactic radiosurgery to the surgical cavity. It directly addresses both goals based on N1070C and the Mahajan trial.
Correct. SRS to the cavity is the standard, balancing control and cognition. Question 2. When performing SRS to a surgical cavity, what is the typical margin added to the GTV, the cavity, to create the PTVA, 0 millimeters, B, 1 to 2 millimeters, C, 3 to 4 millimeters, or D, 5 millimeters?
The margin question. Based on that Stanford data and current practice, it's small but important. The answer is B, 1 to 2 millimeters.
Exactly right. B, 1 to 2 millimeters is the standard PTV margin to enhance local control. Last question, number 3. Which of the following patient or tumor characteristics is most strongly associated with an increased risk of developing nodular meningeal disease, NMD, after surgical resection and post-op SRSA, renal cell carcinoma histology? B, deep tumor location, generally.
Wow.
C, breast cancer histology. Or D, preoperative tumor volume greater than 15 cc.
Okay, thinking back to our BPP mnemonic. B was breast, P was posterior fossa, P was piecemeal. Looking at the options, breast cancer histology is right there. So the answer is C.
Perfect. C, breast cancer histology, is a key identified risk factor for NMD based on the Cagney and Azer study. Fantastic.
Good review. These are definitely high yield points.
Absolutely. So today, we've really covered the modern approach to the post-operative brain metastasis patient. locking in SRS as the standard. But, it's never quite that simple in practice, is it? There are always nuances.
Oh, definitely. While N1070C established SRS, that ongoing discussion about the local control versus cognitive function trade-off is very real in the clinic. You're
Yeah.
always weighing those factors for each individual patient.
Yeah. Is that 61% local control with SRS always acceptable? Are there situations where maybe WBRT might still be considered despite the cognitive hit? It requires careful judgment.
It does. And things like the exact PTV margin, while 1 to 2 millimeters is standard, there's still ongoing research and slight variations in practice. It's a field that continues to evolve and refine itself.
Definitely. Okay, let's quickly summarize the key points from our session today.
Sounds good. So first, we established that adjuvant radiation after resection is mandatory. Observation alone leads to very high recurrence rates, around 50% at 1 year.
Then we dug into the pivotal NCCTGN 1070C trial. It showed post-op SRS preserves cognitive function much better than WBRT without hurting overall survival, making SRS the standard.
We detailed the modern way to contour GTV is the cavity, and you add that crucial 1 to 2 millimeter PTV margin to boost local control.
And finally, we defined nodular meningeal disease, NMD, and highlighted the BTP risk factors: breast cancer histology, posterior fossa location, and piecemeal resection.
But we focused on patients with, say, 1 to 3 resected mets. What about patients who present with many metastases right off the bat, like 5 or more? Or those with really large lesions where single fraction SRS might be too risky, and the big complication radiation necrosis?
Great questions, and that's exactly where we're headed next time. In our next session, Brain Mets Part 4, we'll tackle 5+ Mets, large lesions, and the management of radiation necrosis. We'll explore the expanding role of SRS and how to handle its potential side effects.
Looking forward to it. Lots more ground to cover there.
Absolutely. Remember, you can get show notes and complete practice oral boards over at radoncssmartlearn.com. That's radoncssmartlearn.com. And be sure to subscribe to Radonc Smart Review so you don't miss our next session.
Thanks, everyone, for tuning in.